Thrilled to have you joining us today. I want to briefly introduce our wonderful speakers. Dr. Spira received her PhD from the University of Chicago School of Social Service Administration, and both her MSSW and BS from the University of Wisconsin-Madison. Dr. Spira joined the faculty in 1996 here in the School of Social Work. She teaches courses in both the MSW and PhD programs in the methods and HBSC sequences. Dr. Spira's research and writing focus on older adults and intergenerational families, as well as women's health and the impact of health concerns on family relationships. Dr. Dentato received his Bachelor of Arts and Master of Social Work degrees from Fordham University in New York City. He earned his PhD in social work from Loyola University Chicago, examining the impact of minority stress on substance use and sexual risk among MSM. Dr. Dentato has over 20 years of community-based and consultant experience, including clinical, administrative, and policy work throughout his tenure in New York City, Miami, and Chicago. His text, titled Social Work Practice with the LGBT Community, the Intersection of History, Health, Mental Health, and Policy Factors, was published by Oxford University Press in 2017. Thank you to both of you for being here, and we are so excited to hear what you have to share.
Thanks, Amy, and welcome to a small but formidable group. So we're going to try to keep it informal, and generally, both Michael's style and my style is to travel among you and get a little closer, but for sake of our videographer, we've been asked to stay close to the speakers where the sound is coming from. So please forgive the distance. It's not intended as anything other than convenience. The overview today, I'm going to go rather quickly through my remarks regarding substance abuse in older adults with a specific light on LGBT community, so that we can get to the crux of the matter, which is to use the SBIRT model and adapt it to this problem and these populations. So I'm going to talk about the prevalence, risk and protective factors, comorbidities, something about dependence, and approaches to treatment very, very briefly so that we can turn it over to the focus of the day. So we don't often think of substance use and abuse as a problem among older adults. We think about it as a problem of younger adults, and most of the treatment programs are certainly focused on younger adults. But I want to give you two very brief stories to and share with you where some of the undetected but prevalent situations come up, challenges come up with substance use and abuse. So I was working with a woman who was actually a fairly well-to-do woman. She belonged to a country club, and she was a golfer, champion golfer. And her identity was really wrapped around her prowess in golf, her accomplishments. She described to me one day when she was in a championship tournament, and she went from hole to hole, between holes, stopping at a table where drinks were set up. She went to the first hole and she had a Bloody Mary. Went to the second hole, had a couple of Bloody Marys. Went to the third hole, had yet another. On and on and on. Those of you who are golfers, there's 18 holes that she played, and by the end, pretty soused, right? My client was an angry alcohol user, and so when she got to the clubhouse and people began to comment on her behavior, her appearance, her rather stumbling gait, she became furious and started yelling at them and using profane language. And eventually there were sanctions against her, that they didn't want her to participate in club tournaments, but she should go home, think about things, calm down, and all would be good with the world. Okay? My second story is about a woman who was 82 years old. She had been in a car accident, she had had a stroke, and she was in an acute rehab center following hospitalization. And as her rehab continued and she was able to ambulate with assistance with a walker, she would go from room to room and she would take the Listerine bottles on people's side tables and drink them. When the nursing staff kept wondering, why are these Listerine bottles getting emptier and emptier, they finally were able to channel it back to this woman and realize at that time, I don't think they put alcohol in Listerine anymore, do they? But they found out that she was imbibing in order to get her alcohol fill. She was a Medicaid patient, and it might surprise you to know that she was the one that was sent for treatment. The other woman in the country club was given a pass, overlooked. Let's not see that as a problem, because to do that is to take something that's very important and inherent in this culture, the social experience, and shed light on it. We don't want any publicity about this. We don't want to bring this to light. So it was kind of an interesting experience for me to think that the person I would think would have the least resources and the least availability of treatment actually wound up with the most. Okay, so let's get started with this. So 17% of people over 65 are thought to have a substance use or abuse problem. 13% and 2% consume more than 1 ounce a day, and when Michael talks with you, you'll learn, as was articulated in the news last night, about the 1 drink for women and 2 drinks for men having problems with health later on, that we really need to lower our standards for how much alcohol can damage health. The other aspect of issues with alcohol and older adults is that there's a huge comorbidity factor. Depression and anxiety, which are so prevalent among so many, but not all. I do want to make a case that this involves a percentage of older adults, and that most older adults do not have this problem, can drink safely or not at all, can live their lives with a high quality of life, and that old age, which we tend to homogenize and put in one bucket, is really a 30-year period with many years of hopefully well living, and that's where I really focus a lot of my research and work. So I just want to say we're talking about a subgroup here, so be sure this is not about all older adults. But by the year 2030, the number of elderly suffering with abuse of substances problems will increase, is estimated at 15 million, because the exponential increase in older adults will continue. The baby boomer generation, those born, between 48 and 64, that was in the 20th century, not the 21st, will certainly increase those numbers. And the use of substances, the use of alcohol, the use of other drugs to self-medicate for issues that people are living with longer and better, by the way, will tend to increase. And so we may get into more complications and problems that we need to be aware of. I want to just stop for a moment and highlight the word awareness, because we blind ourselves to so many issues for so many reasons that I'll try to be more specific about in a bit, that we're not aware of what is at the source of many times people's challenges and behaviors. And we look at the symptoms and treat the symptoms as opposed to the underlying sources. And even if we find the underlying source as a substance, we don't look any further to find what the source of the substance use is. So it becomes really critical. Okay, so I said this. The other issues, of course, with older adults is that there is an increase based on age. Age is the biggest risk for the onset of issues with Alzheimer's and other dementias. Dementia being an umbrella, Alzheimer's being the most prevalent form. That's the form that we associate with memory loss, and that is oftentimes comorbid with coexisting with alcohol or other drug use. Sleep disorders, gambling, sexual addictions shouldn't be a surprise to you, right? Our biggest issue and challenge is that the medical system is ill-prepared. This wave of older adult substance users is not screened regularly, and even when they're screened, the screen isn't necessarily looked at. How many of you have been in a doctor's office where you filled out a form and said, do you drink? Do you drink socially? Do you tend to drink once a week, twice a week, monthly? Nobody? Anybody? Yeah, okay, I have too. I don't think my doctor ever looked at the form because I don't look like somebody who might have a substance abuse problem. I don't look like somebody who might fall into that vulnerable group. Why ask? Let's move this along, move our 15-minute session along a little bit. Okay. Doctors ought to know, and healthcare professionals ought to know, and social workers for sure ought to know that age matters, because how alcohol and drugs impact the brain does shift, does shift. Our metabolism slows, so we're slower to get these products out of our system, right? We're more sensitive to lower amounts. So what I could use when I was 25 or 30, the couple of drinks that I could have, however many that was, let's say 3, 4 drinks over the night of a party, maybe only one now will have the same effect. And so the sensitization to the impact of those drugs alters as we age, and we need to really be aware of that as well. What happens? What are the risks? Other medical conditions. Certainly, some of these drugs can be associated with increased possibility of stroke, raising blood pressure, impaired motor skills. Even at low-level use, people can be impaired for driving and or even walking down the street, falls, trip, visuospatial perception may be altered, sleep disorders. Substantial use has even been considered to be associated with suicide, and certain overuse or misuse or misdiagnosis of certain psychotropic drugs we know are associated with risk for suicide even in older adults, not just people 26, which is now the black label on some of the medications that you're familiar with. And certainly the interaction with symptoms of dementia can have profound effects. Higher blood alcohol concentrations, as I said, there's more impairment with blood alcohol concentrations, certain medications, drug-drug interactions, potential interactions, increased side effects. These are the things we need to really be aware of. The question of why should we be concerned about alcohol in older adults, it's not just putting it off because they're old, let them have their pleasure, which is one of the reasons we sometimes give for turning away. There are these side effects that have deleterious effects, and so we want to make sure we look at them. Who's at risk? I wonder if some of these might surprise you. Gender, who do you think drinks more, men or women? Men, yeah. And who do you think use prescription drugs more? Women, you got it. Early onset and a family history certainly is a risk factor. Chronic pain. So we have many more older adults who might be living with conditions that create chronic pain, and they self-medicate. Or they'll say, it didn't do any good. I know I'm not supposed to take it for another 4 or 5 hours. I'm gonna just take it now, you know? And they will continue to accumulate levels in their systems that then produce all these side effects and have big problems. The way in which we self-medicate anxiety can actually increase our anxiety. I'm putting together now substances at large, and I'll break them out in a minute. I know we're mostly talking about alcohol today. But certain drugs, certain of the benzos, for instance, the anxiolytics, have a 4-hour half-life. And after that, there can be a rebound effect where the anxiety, rather than continuing to be suppressed, is actually increased. And so we have to be really, really careful and watch those prescription drugs. Sleep problems can arise and are one of the reasons that people drink more thinking they're going to get better sleep. Actually, alcohol can impair sleep, and certain other drugs can interfere with sleep cycles. I said lack of awareness of metabolic change. People who are homebound, you know, some of you may be aware that one of the growing problems among older adults is not just homebound because of disability, but homebound because of social isolation. And these people are definitely at risk for greater tendencies to drink and use whatever drugs might be available to them. Depression, I've already spoken about, cognitive impairment, and just plain boredom. What do we take away from older adults? What do we remove from them? I always laugh with my students when we go over theories of aging, because the earliest theory, how many of you have taken courses in aging? So one of the earliest theory, I won't put you on the spot to ask you what it is, but it's disengagement, right? That older people are thought to disengage from activities that they had been involved in life, and basically to make room for a younger generation, but because they shouldn't have that responsibility anymore, just relax. You don't have to work. You don't have to produce anything that anybody's going to notice too much. And obviously that was short-lived, and following disengagement came many more theories that endorsed and reinforced the need for activity and purposeful life activities. But some things we do disengage from. And oftentimes the things that are taken away or that we can't do as the result of disability, or simply because we're told we can't do it anymore, forced retirement in some areas, people moving away and dying, not having a social network, and so we've disengaged from our social life, may isolate people, and this puts them at much greater risk. There was another article in the New York Times, my new academic journal of the New York Times, not so new, but they was on how isolation is killing us. And truly, I think across age groups, we need to look at that component. Okay, so boredom that may come from that isolation is huge. Today we're putting a focus on LGBT, and I didn't take Q out of the title because I forgot, but Michael and I talked about this after we did a first run of this presentation a few days ago, and realized that Q is probably not a good addition to our presentation for this population, because in the population of current older adults 65 and up, Q didn't have a good connotation. Was very different than it's used today, and that it may be thought of as really not only dismissive but insulting. And so we're kind of dropping that from the focus today. So this will really be on LGBT. What is the difference? Why talk about LGBT substance users in old age different from other heterosexual LGBTs? Good. Other heterosexual groups. And that is because in addition to the stressors that come with age, maybe retirement, maybe change in activities by the basis of age, physical changes that people have to cope with, that's a whole nother lecture, and loss, the multiple losses people have experienced over life and that accumulate and increase as we age, right? We're much more likely in our old age to lose family and friends and people who are at the end of the lifespan. There are additional stressors and vulnerabilities that are present for LGBT groups. And I wonder if, before I go to them, you have any idea, anybody want to give a guess, just to get your juices running and so you won't have that zoned out look. Yes? Cause? Unless it's a specific. Continued homophobia, right? Sure, that's a big one. Yeah. Anybody else? Legal rights. Legal rights, which are changing, but not always so fast and not always without some difficulty in terms of trying to get them executed and implemented, right? Even when the rights are there. Anything else occur to you? All right, let's move on. Where were you in 1969? Anybody born in this room in 1969? Thank you, thank you. You were born in 1969, okay. That year, okay. Well, that year, I had the privilege of not being at Stonewall, but being on a campus that was protesting for gay rights, protesting against discrimination against gays on campus. And it was the era of the sexual revolution and gay rights. Everybody knows what Stonewall is, right? Anybody not know? In June of that year, there was an uprising at a bar in New York where the LGBT community got together and said no more, fought the police, and it was called a riot in some areas. It was called a large protest by others. It's always in the words that you use to describe something speaks a lot about the way in which you respond to it, right? And so this was a very important turning point in terms of fighting for gay rights. But before that, and most of the people that I'm talking about today were born way before 1969. Were born in the 30s, the 40s, the 50s, or even before, some of them still alive. And we're well aware of the anti-gay discrimination, were well aware of having to hide their identity, were well aware of not being able to live with the person they loved, were not allowed to disclose at work in any way, shape, or form, any part of their social life, hid in dark places and, quiet tones. And so we all whispered about the people always different, right? As if there was something wrong. Well, what do you think the experience of those people might be as they get older? They live in the same world we do, right? And so anybody who lives with any kind of oppression will internalize some of the experience that's all around them. And so we had a lot of people, I know a lot of people, who became self-loathing, who became self-questioning. What is wrong with me? Am I different? What is going on, And began to question their own identities in ways that they carried forth. So now saying you have the freedom to be who you are and to love who you want and experience and let us know, are reluctant still. And so in the places where people might get care in the healthcare system, in treatment facilities, there's still a reluctance sometimes to disclose for fear of what the response is, but also for some perhaps lingering non-acceptance of self or non-acceptance of the experience of interactions with others. Not everybody has felt so liberated. Michael and I show a film in many of our classes called Gen Silent. I wonder if some of you maybe have seen it? Yeah? No? It's about people who did come out of the closet, who were post-Stonewall, felt liberated, felt very much freer, and yet had to go back into hiding when they needed care in long-term care or in healthcare facilities, in the healthcare system later on, right? So any use of substance abuse would not have been acknowledged. They lived in a don't-tell mentality and oftentimes isolated themselves in order to protect, and still those with substance use and abuse problems will isolate so as not to, so everything's in secret. I only drink alone, except that's not part of the culture, right? Where do LGBT people gather to meet other people? As Michael pointed out a couple of days ago, in bars and clubs, right? Where was the protest? It was out of a bar, right? So the notion of how, go back to my lady on the golf course, how alcohol is built into a social group, a social culture associated with the group becomes really, really critical. A lot of people can handle it, but some people can't. And that's the people we have to be really aware of. Oftentimes, studies have shown us that LGBT identified persons are more likely that they're unable to curtail their substance use, and so they're at greater risk for the physical and mental health consequences of it. Becomes really critical. Oftentimes, as I said, they're fearful of disclosing their sexual identity to health providers for fear of rejection, of not being treated properly. I told a story in my other class the other day of working with a transgender woman who had been married, and the ex-wife was originally going to stay with her, and everything was fine. And the transgender woman had a health problem and had to go to the doctor, and the doctor was very rejecting of transgenderism and was not going to treat this person. Said, I don't know anything about this. I don't know what's going on with you. It's too confusing hormonally. I don't know what's going to happen with you. I have no experience. You don't want me. I don't want you. Out. This brought to light for the ex-wife a concern so great that she took her children and left. She didn't want to manage it anymore. This transgendered woman had, for the first time in her life, finally felt she was herself. She felt free, and yet now was faced with complete rejection and loss and isolation. And so it is one of the things that happens in the healthcare system that has ramifications in terms of family structure, in terms of all kinds of issues. The studies also show that particularly lesbians have elevated risks of hazardous drinking, binge drinking, associated with depression, and oftentimes a history of sexual abuse. Bisexual women, too, for some reason, have higher levels of higher risk in this particular area. Studies have found that lesbians are between 1.5 and 2 times likely to smoke, another bad substance use, right, than heterosexual women. And a number of studies suggest that lesbians drink more heavily than heterosexual women. Bisexual women also more hazardous drinking. Oftentimes this results in lower self-esteem because of the impact of the drug as much as anything else, but lower self-esteem may be associated with the drug, right? Poorly developed social networks or loss of social network. Think of aging. Think of the natural diminishment of possible social connections that people endure, and then in this community where there hasn't necessarily been a strong, continuous family tie, especially among older LGBT people, that the loss of social network, the ramifications are huge. Again, isolation, rejection, and resulting in depression. Gay men similarly show that gay men use substances, including alcohol and illicit drugs, which usually are started much earlier than in later life, by the way, at a higher rate than the general populations. And again, with tobacco, I find this interesting. Much higher rates than straight men, nearly a 50% difference in some cases of use of smoking. Now, everybody's aware that smoking isn't good for you, right? SBIRT doesn't yet address smoking, right? No, okay. Data has shown that bisexual adults exhibit significantly higher rates of binge drinking than their heterosexual, I said that. And again, the drinking among LGBT is just much greater. This is interesting because transgender people, marijuana, crack, and alcohol are the most common drugs, but there's a high proportion of people using meth. And some studies suggest, again, tobacco rates are higher, but we don't really understand that, except that there may be, there's a lot more discrimination, insensitivity, and lack of understanding, I think, of this population. And really just, there's been so little research, and research that's been done, by the way, on older adults and substance abuse usually doesn't include sexual orientation as an issue. So the studies are really few and far between. I do want to just point out that there are some patterns of older adult substance use. And that's early onset, before 65, and late onset, which is usually in response to some stressful life situation. That's really critical, because stressful life situations are things that when we begin to work with older adults, we can usually intervene, we can usually work with. It's much more difficult to address the substance use and abuse issues in early onset, because there's a lot of factors that take over in terms of the impact of continued use physiologically, on the impact on the brain, on all sorts of issues that are a really different set of dynamics than late life users. So I think that becomes a critical discrimination to make when you're doing assessments of people. When did you start drinking? When did you begin to use the particular drugs? How do you know that people are drinking? If we're so unaware and we don't look at these screens, how are we going to know? Well, because we're good clinical people and we have a good eye, we can observe that people want to stay alone much more of the time. They may have more memory problems after a drink. They may lose coordination. They may be irritable. They may fail to bathe or keep clean. They may have trouble concentrating. And what else can this suggest besides drug or alcohol use? What else do these symptoms, collections, you clinical people, is there any, who's clinical in here? Absolutely. This can look like depression. This can look like dementia. And if I am unaware of the possibility of substance use being the cause of some of this, I'm going to treat the depression. I'm going to treat the symptoms of dementia and try to improve the quality of life. But I'm not necessarily going to be aware of how important it is to screen for alcohol and drug use, right? I'm just not going to focus on it so much, maybe. What protects us? Being in relationship. No surprise, right? Seems to be the panacea for a lot of stuff, the antidote for a lot of stuff. But committed relationship, social network where there are intimate bonds between people become really critical. A supportive and safe living environment, which, as you brought up, is not always so safe and supportive. If I am not living in a place where other people like me live, I may feel isolated. I may marginalize or isolate myself, or I may be marginalized by others who just kind of push me to the side. I always wonder about the different kinds of discrimination that so many people feel in our world. Those who can hide that which they are being discriminated for versus those that can't. So obviously, racial discrimination, you can't hide the color of your skin, right? I mean, that's something that we're all aware of. And so we have to look at and recognize that both people who have different colored skin or a different, religion you can hide, sexual orientation you can really hide, right? And so it becomes sort of a double whammy, in effect, a double responsibility in a sense, responsibility in quotes, for the persons who feel they have to hold back and not tell. Do they begin to try to look the part of those people in the living environment that really isn't them, and then create another not me experience? The tendency for people to try to blend in, to pass, if you will, terrible word and process that many people have gone through across different sorts of vulnerabilities and populations that have been oppressed, where people try to be part of in ways that are not true to themselves. And eventually, that not being true to self, again, has its own ramifications, right? Very deleterious to issues of confidence, self-esteem associated with depression, and guess what? Alcohol and drug use. So it becomes really, really important. We need to begin to realize that we need to screen annually in primary care offices or in social service agencies, but look at the screens. I always worry about my students who, over the years, tell me about the quick assessments they need to do. They get 15 minutes and a long checklist, and they've got to go boop, 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 boop. Got it, not. What happens to that information? Becomes a face sheet, goes on to a computer program. Do we ever really look at it and say, oh, I see that your drinking is really pretty frequent. Can we talk about that? Michael's going to address that, so I'm not going to spend time on it. But do we ever look at the screen, other than maybe a little bit more, is anybody hurting you at home? If I said yes, I suppose somebody would address it, right? But I will say that other than that, no one has ever asked me, as I have become an older woman, if I'm abused in any other way. Has anybody tried to financially exploit you? Has anybody tried to call you names or bully you? Nobody ever asks me that. And nobody ever asks me how much I drink. They don't. So if I use other drugs. And I have to say that in my portion of older adults, alcohol initially was not the problem, was not such an issue. Because in my era, in the 60s and early 70s, drinking was not as popular as other sorts of drug use, right? Not inhaling, but other sorts of things, that people used. This was the era of people experimenting with levels of consciousness, with psychedelic drugs, or lots of marijuana, and things that we didn't know about before, but were replacing, it seemed, alcohol. And then something happened. Older adults, as they aged, began to drink more, perhaps, and do both. Now, lots of people I know are still popping edibles and using drugs, but hopefully, and those are being even less screened for, by the way. People might say, do you smoke? But nobody's ever asked, do you swallow cannabis in any other form? Nobody, right? Clients that I've seen across the board, Okay. Barriers to identifying and treating older adults. There's a lack of awareness of the chemicals' effects. People don't know. SUDs often mimic other disorders we've talked about. Healthcare systems oftentimes have this 15-minute managed care mentality. If they touch you, they get to charge for a full examination, but most places where people go for medications, for instance, are 15-minute sessions, right? So older adults may go undetected. LGBT older adults especially go undetected. People are in denial about the impact that use is having on their bodies. It makes me feel good. I'm a party person. It's how I interact. I consult in a lot of long-term care facilities. They all have, now they have built-in happy hours, you know, where they allow a little bit of alcohol, a little bit of socializing. Maybe it's watered down, I don't know. But oftentimes, people protect their families. Familial shame will prevent adult children from saying, I think my parent has a problem. I think there's a problem here. DSM is not kind to older adults. The thresholds are much too high for identification of diagnoses. I don't like those labels anyway, but for insurance purposes, really the thresholds are way too high for older adults. Ageism continues, of course. Homophobia, especially among older LGBT, I think is still pretty rampant. People can think, oh, aren't they great, these young people who are in partnerships, and you know, look how much fun they're having, and you know, how colorful, blah, blah, blah. Yeah, well, when they age, tell me how much you think they're cute, you know, and how it brings back and triggers some of those old messages that become really critical. So homophobia and lack of age-specific treatment programs. Especially for LGBT, the stigma continues. They are unlikely to report. We are unlikely to ask. We don't have any culturally competent tools and interventions, although Michael's going to try to bring one to you that can maybe work towards adaptation. The comorbid physical illnesses, lack of awareness, and this elderly mask presentation via somatic symptoms. This is critical. Older people present with physical pain or physical problems, not emotional ones, right? I'm fine. I just have these pains. Why do I have these pains, doctor? Well, you're old, is often the answer they'll get. And it's no different for LGBT. That becomes really, really important. They will be more comfortable bringing forth physical complaints rather than emotional or behavioral issues with. I want to, before I end, because we've been talking a lot about alcohol, but throwing in some stuff about other drugs, but what do you think, what type of psychoactive medication is associated with most emergency room visits? What do you think? Bingo, absolutely. Pain pills, look at the difference, 43.5%. How do we understand that? Because people are prescribed pain pills, right? Post-surgery, go home, you need this to recover, you'll feel better, I'll take a little more. As I said, it's not working fast enough. These are the most abused opioid medications, and they are prescribed often. The scope of the problem of opioid deaths, we know, is huge. We hear this in the news all the time. We don't have time to really focus on it today. And your presentation, Michael, is going to focus mostly on alcohol, right? But is applicable to these. But I think it's really important to realize that it's not the alcohol abuse, though that's the most commonly abused drug, that brings people to emergency rooms, which brings them to light at all for having a problem, but it's opioids. A woman I worked with who was in a very bad car accident, shattered her pelvis, lots of other bones, was given opioids in the hospital, sent home with them, 73 years old, wound up having to go to rehab. Could not get off the opioids. A little bit of a bar graph to show you the death rates. Pretty impressive. Signs and symptoms, again, confusion, depression, delirium, insomnia, Parkinson's-like symptoms, weakness, lethargy, loss of appetite, falls. But if you didn't know that opioids were prescribed and you didn't ask your client, what drugs are you on, you may not associate drug use with these. That's what I want to keep stressing. You see people with symptoms that can be lots of things. Don't make assumptions. Make drugs part of your assessment. What are they taking? Do they know what they're taking it for? Prescriptive drugs for sure, benzos, which can result in these falls, which can result in sudden death in some cases. You need to explore what they're taking. Where are you getting them? Do you know what they're for? How often? And to find ways to do it in a non-shaming and non-judgmental way. So in summary, what do we need? Trained social workers. Not only are only 4% of social workers getting training in gerontology, people sensitized to drug use with older adults is even less. And the numbers are going to be greater. Supportive families, social supports, consistent and regular screening becomes critical, and early interventions that explore culturally sensitive services. In terms of where to get the training?
Well, no, in terms of
Their training is initially in school and in continuing education, like Dr. Dentato provides, and their placement, their workplaces are everywhere. So yes, hospitals should train social workers. Further training should be continuing ed for social workers within hospitals. Long-term care, absolutely. Mental health centers, family service centers. I can't think of a place not.
yeah, I guess.
Yeah. So places like Howard Brown and those sorts of facilities that we hope will become more. But I am eternally hopeful that other sorts of agencies become inclusive of culturally sensitive training, even in these other places. Because if people in their old age feel they need to hide their identity, I want to, in the least confines of my office, make it comfortable enough to be able to share truth. And not believe that I have to stay silent, that I have to become Jen silent, that I can be who I am with you. And, maybe I'm naive, hopeful. Gotta be hopeful about something these days, right? So engaging and retaining, SAMHSA came out with these methods of integrating, maybe this answers your question in part, but integrating all of these services to provide comprehensive, holistic, person-centered care. And I say person-centered, but I really mean relationship-centered care, relationship between social worker and client, as well as with client and their support systems, their dyadic relationships or triadic relationships that they're involved in, right? If we had more time, we would talk about what some of those interventions would look like, but I'm going to turn it over to my colleague, who is going to talk about a model that will enable you to make use of some of these treatment approaches, including cognitive behavioral psychiatric approaches. People, once given the opportunity to talk, and once they have gone through detox if necessary, are pretty willing to talk. Harm reduction, case management, family support, group-based counseling. So there you go. All of these trainings I would love to see implemented in agencies, and that they can call on experts like my colleague to talk about it. We could do it together. So I want to thank you for your attention, and I'm going to, unless there's questions, I'm going to take leave and turn it over to my very esteemed and expert colleague, Michael Dentato, who will talk about expert. I was going to say expert. Xbox expert. Yep, got it.
We'll make the PowerPoints available to you after this training. All right, well, good morning and welcome to the second half of the presentation where I will try to make the bridge between early intervention and screening for alcohol and drug use, and specifically weave in how that pertains to practice with older LGBT adults. But I just want to thank, again, Marcia for kind of teeing up this piece. Frankly, the research and literature is limited, as Marcia mentioned already, with regard to specifically looking at LGBT substance use issues. A large amount pertains to cisgender gay men and maybe lesbians, very little about bisexual population, a growing literature on transgender and gender nonconforming populations. So there's a lot of work ahead of us. SBIRT in and of itself, frankly, has been researched predominantly with regard to its impact on alcohol use. So even with regard to substance use, there's still a limitation in what we're seeing out there with regard to the evidence-based scholarship. So I'll talk a little bit more about that. Who's heard of SBIRT? Just curious. Never? You have? Are you using SBIRT? No. You are?
Sure.
Where do you practice?
I work,
Great.
so
Okay.
so that includes
Oh, terrific.
yes.
So you should be here and I'll take a seat. Well, I hope this isn't too duplicative of what you heard, but I guess you can't hear it enough to bring it home. One of the barriers that we are seeing with regard to the model and use of the model is implementation. So a lot of people have heard of it, they kind of understand what it is, but they're not using it and not implementing it. This is a national problem. This is not just a local problem. The project that I'm going to talk about is part of a grant through SAMHSA, Substance Abuse Mental Health Services Administration, part of the federal government. And this is the team that I've been working with over the past year and a half to provide classroom-based training here at the School of Social Work, Nursing, and Medicine out at the Maywood campus. But also community-based training within organizations, an advanced certificate program for students in an interprofessional training platform, and we're evaluated by a local colleague down at University of Chicago and ORC. So SBIRT, in essence, is really these 3 or 4 different stages of providing a universal screening for a quick glimpse of whether or not folks are using alcohol and drugs and what frequency and intensity they're using alcohol and drugs. As Marcia just mentioned, did you hear this on the news? Literally yesterday, the day before today, there's a longitudinal study that was looking at the limits and usage of long-term alcohol use. So even the standards that I'm going to talk about today with regard to men and women and the number of drinks that's suggested per day, this study knocks that out of the water. So while I'm trying to give you the most current information, I love the fact that this study just came out yesterday. And I love that we're still looking at the impact of even 1 drink per day regardless of gender, right? Regardless of age and what the impacts are short-term and long-term. Anyway, I digress for now. So after this quick screening, once you determine whether or not somebody is at risk for some severity of problems with regard to alcohol or drug use, you either make the determination to go into the brief intervention or not. The screening may be quick and done, and that's it, if they are low risk or no risk, right? The brief intervention piece is really based in the components of motivational interviewing, which we'll talk about a little bit later, and the brief negotiated interview. Based on how that process goes, then you might want to make the referral to treatment, and whatever that means, inpatient, outpatient, 12-step, so on. So again, just historically, when we think about stigma, we think about taboo. As Marcia alluded, when we talk about diverse community, marginalized groups, specifically older adults, specifically older LGBT adults, right? We have to determine whether or not they are curious, interested, and willing to talk about their alcohol and drug use. This one study specifically says that most patients, more often than not, are willing to talk about it. So if we are not willing to go there with them as practitioners, we are just continuing to fortify and promote the stigma and taboo associated with alcohol and drug use. Again, as Marcia mentioned before, I go to the doctor, I fill out that form every year, I get my annual evaluation, and he yells at me because I need to lose some weight. Same thing for how many years now, right? Can't win. I completely always fill out alcohol use, smoking, you know, answer yes, no, frequency, that kind of thing. Never says a thing. So I almost want to trick him the next time I go and write, you know, 5 drinks a day, smoking incessantly. Not true, not true. Just to see if he picks up on it or if he really just glances over it. We well know, again, that there are myriad challenges and problems with regard to alcohol and substance use. The impact upon one's health, mental health, both short-term and long-term, let alone ongoing challenges with regard to public safety and public health as well. So this is curious, right? Let's look at this for a minute. Evidence indicates moderate and high-risk drinkers account for the most problems. Well, a high-risk drinker is down here in the brown area, compared to the moderate drinkers here in the green area, and then the light drinkers. SBIRT is really about capturing these folks before it gets too far, okay? With regard to the impact, again, on not only health, mental health, physical health, places of employment, you know, impact on friends, families, and potential for accident as well. So just another way to look at this, that clearly there are dependent users and then these at-risk and binge drinkers. We want to get those at-risk and binge drinkers before they become dependent. So in the paradigm of public health, when we look at frameworks for both early intervention, treatment approaches, and maintenance approaches as well, SBIRT falls in the early intervention category, compared to the ROSCs or 12-step groups and so on. And the goal is to identify and effectively intervene for those who are at moderate to high risk for psychosocial or healthcare problems related to their, you know how many times I've given this presentation, I forgot to put alcohol in there, alcohol or substance use. So what does research also tell us? That these types of brief interventions are cost effective. Again, most effective with those with less severity of problems, are highly feasible and can make an impact in reducing illicit substance use. Again, some of the challenges we've been hearing here at Loyola with regard to our hospital and our clinics is incorporating additional questions for the screening for SBIRT within our electronic health records or our paper intake form. So we have this grant and we have our own challenges, right? So again, it's not unheard of that folks are really interested in this and interested in incorporating it within their diverse practice setting, but not willing to kind of take the next leap in doing so. So back to an earlier question, Sam, is that your name? That you asked about kind of where does this training need to happen and who should be doing this. I agree with Marcia. It needs to be incorporated everywhere. When we talk about practice with older adults, it should be inclusive of intersectionality factors, and that's race and ethnicity and socioeconomic status, sexual orientation, gender identity, and expression, and so on, at all of these areas, right? So that SBIRT is not just utilized within a traditional emergency department, right, within a traditional healthcare practice, but within a senior service center, inpatient, outpatient, schools, in the VA, homeless services, psychiatric care, homeless facilities, and so on. So at this point, I'll bring you through the pre-screening process and talk about a couple of screening tools that are the most frequently used. Again, I'll make the PowerPoint readily available to you if you even want to use the PowerPoint at your agency, and you know all of the tools. Everything is free. It's all online. SAMHSA provides all of it, so you shouldn't pay a thing for any of these tools. So the rationale for universal screening, again, just to recap, that drinking and drug use are common amongst most populations, right, including older LGBT adults for many, many reasons, historically, generationally, as Marcia mentioned earlier, that clearly it can increase problems related to health, mental health, safety, and other issues, that often it goes undetected, right, or it's dismissed. Oh, I don't have a problem. It's just one drink a day, a couple glasses of wine while I'm cooking, not a big factor. It doesn't impact the way I work. It doesn't impact my friendships or my relationships. Lots of denial. And again, lastly, that people are more open to change than you might expect. So the NIAAA single question screen for both alcohol and drug use for a negative response based on previous experiences and research with the SBIRT model, this type of screening will yield 75% negative responses. Translation, 75% of the folks through research that have been pre-screened are not at high risk. So that's it, it's over. If that person says, I don't drink, I'm in recovery, clearly they're at low risk, right? If that person says, no, I have a family history of alcohol and substance use, never touched the stuff, clearly that type of client or patient is at low risk. Compared to a positive screen, right? And this sense of frequency, intensity, and quantity as well, right? How much really matters too with regard to the ounces of each drink. So if that's positive, then you move forward with the second stage, which is the brief intervention. So here's a NIDA quick screen form that you can use and incorporate. And what I like about this is that it is adaptable. So we're seeing, clearly this challenge with vaping, and especially with youth and with adolescent populations. So if you specifically wanted to adapt this form and underneath it say, well, I wonder about how often in the past year you've smoked cigarettes, and the youth or the adolescent says, I don't smoke cigarettes. Well, how often have you vaped? Oh, I vape every day. Right? So notice the difference in just generally asking about tobacco use versus being more explicit and talking about differences between cigarettes and vaping compared to the frequency of drinking, right? So again, here, we'll talk a little bit about some age differences when we look at screening for alcohol use, but these standards right now are set by SAMHSA. For men, 5 or more drinks a day. For women, 4 or more drinks a day. I think that's a lot. Now, I'm not judging, but again, we're not taking into consideration age, we're not taking into consideration body weight, again, we're not taking into consideration other factors such as impact on daily living and so on. Again, just this sense of being a little bit more explicit here, because if you ask your patient if they take illegal drugs, what does illegal mean to them? Aren't all drugs illegal, right? Except for marijuana for medicinal use in our state. Prescription drugs for non-medical reasons, I'd want to talk more about that, right? So have you been through a surgery lately, or did you borrow a couple of your, partner's Vicodin or Adderall or so on? So with this quick screen, if the patient is basically falling into this category, low risk or high risk? Low, right? If their response is over here, then clearly you want to move forward with the screening. So again, these are the current standards that I'm going to use, but I'm fascinated by the study that just came out that specifically looked at 1 drink per day. Fascinating. So positive alcohol screen, we'll go through alcohol first, then I'll go through drugs. Binge drinking, greater than 5 or more drinks per day for men, or greater than 4 for women or anyone over the age of 65. If the patient, exceeds regular limits, men, two a day or 14 a week, women or anyone 65 or over, 1 a day or 7 per week. So again, look at the differences between what SAMHSA is categorizing as binge drinking compared to regular, ordinary limits, right? Fascinating. If it's no, they're low risk. If it's yes, patient is at risk. Screen for maladaptive pattern of use and clinically significant alcohol impairment using the audit. So the audit is for alcohol, the DAST is for substance use, and I'll talk about each of those now. Questions so far? Reactions? What do you think about these limits? Bends? Right. Again, think about older adults, older LGBT adults that may have some level of cognitive impairment or physical impairment. Even 1 drink of straight vodka on the rocks compared to a 4-ounce glass of wine, right? Think about that. Think about the impact it could potentially have on them. So yeah, we've got to look at each person individually. When I was trained 20 years ago on this, before SBIRT, right, in my MSW program, it was always about assessing the impact on daily living, right? So if it has an impact on the ability to get out of bed, on the ability to get to work, to function, to be a good partner, eating, drinking, sleeping, there's probably a problem. So it's a more formal way of saying it. So the audit is the Alcohol Use Disorders Identification Test. It's 10 simple questions. It can be self-administered, or it can be administered through a one-to-one interview. Looks at recent alcohol use, dependent symptoms, and alcohol-related problems. It was developed by the World Health Organization. So I'll pause there. I love to ask this question. Do you think patients and clients are more likely to be truthful and authentic if they're filling these forms out themselves in a waiting room or on an iPad, or if you're meeting with them one-to-one and you administer this test with them one-to-one? What do you think? Privately one-to-one? Okay. Anyone think the opposite? Oh, if you're doing it yourself, you're going to be more honest. Does anyone think the opposite of that then? That a patient or a client's going to be more honest with you in person? No, you think by themselves, right? I think the jury's out, frankly. I think if it's the first contact you have with that patient or client and you haven't established any trust, I'm not sure they're going to be that honest and open with you, right? Versus filling it out alone in a waiting room or on an iPad. If this is a client or a patient that you're seeing on an ongoing basis, at a nursing home, assisted living facility, in a school, wherever your patients are, I think if you have that level of trust and therapeutic alliance with them, hopefully they would be honest and open with you if you're going to continue administering these screenings. What do you think?
And this is
Right.
so I think we really
Sure.
don't know how to stop.
I think it's about normalizing. I think that, setting a client and patient up, whether it's at legal aid or again at a nursing home or in a school, and saying, Sam, this is part of our intake process, and every patient or client or, that comes through, we ask all these questions. And the reason that we ask these questions is, we found that alcohol and drug use can have an impact upon, foster care, whatever issues that you're dealing with, legal services, and whatever. So we appreciate your being open and honest with us, and we'll talk about what these results may or may not mean for you. So I think the more you go in genuinely and authentically and say, this is just a standard part of our practice, as much as it is we ask your name, social security number, address, things like that. The more we normalize this, the better. So that's my quick response. So here it is. You probably can't see that, but I'll read some of them for you. So how often do you have a drink containing alcohol is the first question. And the categories range from 0 for never to 6 for daily. So if I'm drinking daily, a 6 goes here. I'll skip down a little bit. How often, number 4, how often during the last year have you found that you are not able to stop drinking once you've started? So for number 4, it's, again, you score 0 for never or 4 for daily or almost daily. Well, again, if I'm a 6, a 6, a 6, a 4, you kind of get that I'm heading towards that high-risk category, right? Elementary, my dear Watson. So again, once the patient goes through this and scores themselves, or you score it with them, you then have great evidence to say, sorry you're in the front row, Sam, and I can see your name tag. Sam, I'm wondering if we can talk about the results from your audit test. Too animated Italian, I can't stop using my hands. Sam says, yeah, Michael, let's talk about that. I'm wondering what this means, right? It's a wonderful moment to provide that feedback, and that's a key part of the brief negotiated interview and motivational interviewing, is asking the client's permission. So we'll get to that. Anyway, the rest of the audit, talks a little bit more about number 7, how often have you had feelings of guilt or remorse after drinking? Number 8, blacking out, right? The sense of being able to remember what happened the night before. Number 9, about injury. Have you or someone else been injured because of your drinking? And then thinking systemically, this number 10, has a relative, a friend, a doctor, another healthcare worker been concerned about your drinking and suggest you cut down? So as an example, I'm sorry, I'll get to that in a second. So here are the zones for scoring the audit, that for dependent use, those that are scoring 20 or greater clearly are probably going to need some type of referral for evaluation or treatment. That, again, based on current research, is about 5% of the folks that we're finding through use of the SBIRT model. Again, compared to these low-risk folks that need some type of screening and feedback that is not a referral for evaluation and treatment. So depending upon the score, you will determine whether that patient or client is at low risk, at risk, harmful use, or dependent use in order to move forward. So here you see one example, right, where the person is predominantly scoring more towards the 0, never to no categories, possibly 1, possibly 2. Where do you think they would fall on the risk levels that I just described in the pyramid before? Low risk, at risk, high risk, dependent use, low risk, right? So again, what I love about this is it's science-based, it's kind of effortless, and it's kind of easy, right? It's an easy way for you to get some insight and glimpses into a patient and client's alcohol use. So again, just another way to look at this. What is their score? What is the risk level? And what do you do? So later on when I get to the referral to treatment piece, right, that's very city, county, state specific. Like you've got to know potentially what services are out there, what access they are going to need with regard to health insurance or Medicaid, Medicare coverage, what services or programs are available to them within your organization, down the street, or so on. But again, just to briefly look at this, so this is flipped. So zone 1, the low risk use is at the top. The intervention is to provide feedback. The scores are there, and is there a possibility for an alcohol use disorder? DSM-5, ICD-10, probably not at all. Compared to a high-risk probable substance use disorder, you're going to have to refer for evaluation or treatment if you don't do that within your own setting. And again, there probably is some level of severity for dependence. Oops. Similar to what I just went through is the DAST, the DAST-10, and the screening process to look at substances. Again, what is kind of curious is that in folks I've talked to with regard to barriers to implementation, it's like they can get the alcohol piece done, but they can't put the substance piece in. And I'm like, there's no way you can combine the questions, or it's just fascinating that folks are, and I get it, because how long are these intakes already? How long are the psychosocials already? How long are the process, not only for new clients and patients or existing clients and patients, but also for staff, So a doctor comes in, before you see the doctor, who do you typically see? Nurse practitioner, right? Somebody like that. What's the length of time these appointments take with you? How long is your typical medical appointment? 2 hours? How many? About 20 minutes. What's that? Oh, you're lucky. I would say that on average, they could be about 15 minutes, right? And again, depending upon your health needs, depending upon your history, like that kind of thing too. I have a skin disorder issue, so I go to the dermatologist all the time. First intake was about 15, 20. Now it's about 7. We probably spend more time gossiping than we do talking about my skin care. Never talks about alcohol or drug use. So I just, every time I go back, I'm like, I've got to poke and just be like, yeah, things have been tough at Loyola, and I've been drinking a little bit more than usual, just to see if he says anything. And I know he's going to say, is this a test? Anyway, the pre-screening for drugs. similar to what we just talked about with the audit, is just a quick question. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? For instance, because it made you feel good or the experiences that you have. If the response is none or never, the screening for substance use and drugs is complete. If it's not, and there is some ambiguity or some response that talks about severity, frequency, amount, then you want to use your clinical judgment and move forward. So the DAS-10 consists of screening questions for at-risk drug use, yields a quantitative index of problems, is a sensitive screening tool for at-risk drug use, does not include alcohol use. They are looking at, and you may see some of this on SAMHSA's website, combined screening tools now that look at both alcohol and drug use. So here's the questionnaire. And these questions pertain to drug use over the past 12 months. And again, I'll just highlight some of these. Have you used drugs other than those required for medical reasons? Yes or no. Number 3, are you unable to stop using drugs when you want to? Yes or no. Blackouts, flashbacks, guilt. 6, spouse or parents, family, friends ever complain about your involvement with drugs? Have you neglected your family, engaged in illegal activities in order to obtain drugs? Do you ever experience withdrawal or felt sick when you stopped taking them? Have you had any other medical problems as a result of your drug use, right? So again, if this client is saying yes all the way down, what are you thinking? Low risk, high risk? High risk, right. So just another framework to look at the scoring, that if their score is 0, they're not reporting any problems, then there's no suggested action that you need to take at this time. Compared to a score 6 to 8 or a substantial level in which you need to provide some level of motivational interviewing, brief negotiated interview, potential referral to treatment. Sorry. So again, example of low risk, they're saying no to everything on this tool. What is the score? What is the risk level? What do you do? So for those at low risk, again, from a motivational interviewing framework, you want to provide reinforcement for that, right? So if their score is low or 0, right, not using a lot of alcohol or drugs, you might want to reinforce it. You know, Sam, looks like you're making some great decisions about your use of alcohol and drugs. Keep it up. Do you have any questions for me about what alcohol does to your health or mental health, or what substances do to your health or mental health? Client says, no, I know what's going on. You're okay. So I'll just briefly go through the highlights of motivational interviewing because they are clearly an important piece of the brief negotiated interview, or the BI of SBIRT. Clearly, the tasks of motivational interviewing are to be able to engage with your clients specifically about these sensitive and taboo topics, specifically kind of connecting this to older LGBT adults, again, kind of meeting them where they are, understanding that they may harbor some internalized homophobia, transphobia. They may have experienced the same over their lifetime because of oppression, because of their sexual minority status, because of the ways in which society has evolved to be more affirming. But again, we clearly have some room to grow. Marriage equality wasn't the end-all and be-all for the LGBT community. And focusing on what's important with regard to their behavior, their health and their welfare, prioritizing that, right? Not telling a client what you think is important, but engaging with them and asking about what's important to them, and evoking their motivation for change, their readiness for change, that readiness ruler that I'll pull out in a little bit, right? Where are they with regard to motivation and readiness to make a difference in their life, or not? And then again, Lastly, working with them to negotiate a plan, right? So what does today look like? And what is tomorrow going to look like, let alone next week? This is tough because sometimes, depending upon your setting or your interactions with patients, you just may have that 20-minute, 30-minute moment with them, and that's it. So it is about planting seeds. It is about hoping that you've at least made some small impact on them so that they will think and consider about making a change. This is clearly easier if you have an ongoing patient or client that you're seeing weekly, monthly, or so on. But motivating folks often means clearly helping them resolve conflicting and ambivalent feelings and thoughts, right? We all kind of know what we need to do, but we're all guilty of not doing it, right? If I went around the room, I'd say, how often does your mind say one thing, but then you disagree with it and make other decisions over the lifespan? So motivational interviewing is really about this collaborative process and relationship of engaging with your clients. It is not using confrontation. SBIRT in and of itself is really based on a harm reduction model. It's kind of difficult at times to have conversations about harm reduction when settings or folks have a very firm grounding in abstinence-based models, so that can be conflictual at times. It's about evoking change for response. There is, I'll differ with this slide for a minute, there is some level of education that's important with regard to the SBIRT model, but not like you want to stand up here at this big podium and point a finger at a client and say, now you know better about alcohol and drug use. You might want to say, Sam, what do you think some of the concerns are for folks your age with regard to long-term alcohol use? Sam's like, I know it's not good for your liver. I've heard that over the years, and and I'm 75 years old, and I know that I'm more frail than I used to be, So getting that client to at least elicit that education from the client as well, rather than just provide all the education to them. MI is also respectful of autonomy and not authority. Again, so critically important with older adults and older LGBT adults, right? You want to enforce and really support their autonomy in all ways, shapes, and forms. And clearly about being compassionate, empathic. So based on these 4 areas, a lot of work by these folks, Miller, DiClemente, Rolnick, a lot of great articles out there, books out there about motivational interviewing. It is, and we'll go through each of these briefly, about the effective and impactful and authentic expression of empathy. It is about developing discrepancy and pointing that out for clients, rolling with their resistance to create change, and supporting their self-efficacy as well. What's empathy? Now, you all know this. When I just asked that Marcia and I mentioned that we did this with students, and we ask about empathy, and they just look at us like, I don't know. What's empathy? How do you effectively express empathy? Or what does it mean to you in your practice? Okay. Others? Gotta get you guys engaged. This table's way too quiet. What's empathy? Table number 1. Give it a shot. Great. So both verbal and nonverbal communications can express empathy, the framework by which you think about putting yourself in another person's shoes. Right? So reflecting back not only proves that you're listening, right, but that you're genuinely kind to be with them and be empathic about their position and where they are. I think it's also about this conveyance of not understanding their situation too, and not even attempting to do so, right? When I've expressed empathy, I've often said, I can't imagine how hard this has been for you, right? If this is someone that's, again, use an older LGBT adult who has gone through generations and decades of oppression with the relationship, again, think of the pre-Stonewall folks, with regard to societal implications for stigma, with regard to employment, policies, inability to have their relationships recognized pre-2015, right? Even as a post-Stonewaller, right, I can't imagine what that life was like. Even the oppression and stigma and bias that I faced through the 70s and 80s and 90s is different in different ways than it was pre-Stonewall. So empathy does communicate acceptance, encourages the sense of a collaboration, the therapeutic alliance, helps with promoting change, and leads to understanding of each person's unique perspective. That's kind of what I was just trying to drill down on. Their feelings and values, which really make up the material that we need to facilitate change. For me, empathy is also about underscoring resilience, right? Our clients are so incredibly resilient, and they quite often don't see that, feel that, or sense that. They come to us thinking we have all the answers, right? And I love that, because they would come in and be like, you know, Michael, thank God you're here. And I'm like, oh, no, this is not about me. This is about us, right? And this is about me helping you understand the power, the tools, the resilience that you have from within in order to make a change. I'm part of that process, but I am not the whole process. So this second piece, again, looking at ambivalence, looking at readiness, looking at ambiguity, how are their current behaviors inhibiting them from achieving their future goals? Client, patient says, you know, I'm 80 years old, I've had a long life, I've been really distant from my family, you know, but I want to reunite with some family members. One of the ways that I deal with it is by drinking a lot, numbs a lot of the pain, right? So think about the messages. I'm numbing the pain because I'm drinking a lot, but I really want to reunite with my family. You know I'm 80, I'm very frail, maybe I've only got a couple years left, right? So how do you help that client look at the discrepancy with regard to feelings versus actions? And how do you help them kind of change those actions, maybe modify some of that drinking in order to focus on that reunification with extended family members? Rolling with resistance, just one quick example. Client says, again, my husband's always nagging about my drinking, always calling me an alcoholic. It really bothers me. You note, well, I wonder if, let's flip this. It sounds like he's expressing his concern in a way that makes you angry, but I wonder also if it's about him really caring about you, about expressing concern to you too, right? This sense of rolling with a client's resistance in order to create change. And clearly about supporting their self-efficacy, that, again, our clients are resilient. They have often the tools and the resources and the moxie, term I love, in order to really kind of step up and think about creating a change themselves. I think we need to elicit that from them. And your task is really, with regard to supporting self-efficacy, supporting this belief that the possibility of change is an important motive factor, and they can do it. Right? They can do it, some on their own, some with our support and other resources. A brief acronym to just remember some of the basic skills of motivational interviewing. Using open-ended questions. Clearly, we don't want to use close-ended because they can typically be responded to with a yes or a no. Using affirmations, providing an affirming approach to your practice with clients in your settings. Being reflective, again, as you just mentioned before, the sense of conveying understanding, conveying empathy. I hear you, I'm with you. Restating what they're saying can be quite affirming, because for many, they've never been listened to before. And while there are many of us out there that are phenomenal social workers, nurses, doctors, practitioners, whatever the profession, there are equally those that are really bad, right? So we can probably assume by the time our clients have come to us, they've seen a lot of good and they've seen a lot of bad. So, and then summarizing, again, trying to tie this all together. So, Kira, I appreciate everything that we've talked about today. I'd like to review some of those things. Your alcohol and drug use has been increasing. It's been creating some challenges for you with regard to your place of employment, because you're showing up late, you're not as productive, you're lethargic. You really want to create a change because you're thinking about retirement. You want to go out on a really good note, and you're willing to make that change. So does that sound like what we've been talking about for the past 10, 15, 20 minutes, 40 minutes, whatever the session is? Client, patient says, yeah, that's it. So just some examples, again, of these 4 areas. The kind of the open-ended question that's inviting to think, let a client think a little bit more before they respond. How do you hope things would be in a year from now, 2 years from now, 5 years from now? I call it the Cinderella question. Being affirming. So again, I noticed you really made a great effort this week. I appreciate that tremendously. Being reflective. It sounds like you've lost a lot. And then again, summarizing, pulling it all together. So one thing that you hope that'll be different in a year is this or that. So again, here's what you've told me so far. Questions? Yeah. I think you are truthful, authentic, and say, Kira, I've just met you, but I really appreciate you being honest with me. And even though I may not see you again because you're going to go to this department or that department or you're being discharged, I just want to take a moment and just say how I really appreciate your honesty, truthfulness, openness, authenticity, whatever it is, about this matter. I think that's real. If it is real, I wouldn't make it up, right? Because our clients will call us on it like, what's this crock that you're trying to sell me? But again, I think it is about planting those seeds. Like maybe you are that one person in your 20 minutes with that patient in the ED that creates a change. Because you said to them, Michael, I just want to say I appreciate how honest, open, truthful, authentic, whatever the term is that you pick, how authentic you've been with me in this short time. And I may not see you again. I just wanted to take a moment, just say thanks. I appreciate that, right? Client would probably be quite appreciative of that. No one's ever said that to me before. So, that help? Yeah, why not? I mean, honestly, if they really are that open and honest and genuine with you, and it is about, again, in this example for this training, about their alcohol or drug use, I want to pat them on the back and applaud them and say that, I believe in many ways you probably have the ability from within to make a change, but you've got to be a big part of creating that change for yourself. Other questions before I move on? So the brief intervention, based in motivational interviewing, and again, this is funny because as I've been talking about barriers to implementing SBIRT, everyone thinks this is like an hour-long process. This can all take place in as short as a minute, if they're low risk, or as long as like 5 to 10, 15 minutes, And again, when we think of some of the barriers that we've seen, some of the doctors, not to place blame only on the medical profession, are clearly always worried about timing, right? Because of billing and then the ways in which they're reimbursed and other challenges that they've seen over the years. But it is a quick process, and it can be a fairly quick process. It can also be used in an interprofessional fashion, so that someone does the screening, someone does the brief intervention, and someone does the referral to treatment. So you can do a warm handoff, right? If I'm the intake coordinator and the screening is screens a high potential, I then hand off to the next professional, and that professional, and I won't say social worker because we are going to assume that the social worker always does the brief intervention component, and let's not make those assumptions, right? That if we are effectively training people on the SBIRT model, any profession can do any component. So, and that's a big part of our advanced certificate program, teaching medical students, nursing students, and social work students about this piece too. Not to make assumptions that the nurse does the screening, the social worker does the brief intervention, and the doctor just waves from down the hall. So based again on motivational interviewing, this is an evidence-based practice, and the brief negotiated interview, or the BNI, can really happen in as short as 5 minutes and as long as 15. Some of these concepts, again, will be duplicative from what I just mentioned, but it is about rolling with resistance, expressing empathy and empathic attitudes towards your clients and patients, developing discrepancy, and supporting their self-efficacy. So, even in the emergency department with 15 minutes with a patient, you can establish rapport. You know, even again, at the first intake at a legal aid clinic, if you're just kind of that person at the front door, or you're some short part of the intake or application or service delivery, you can establish rapport, right? It is just about that being real, being authentic, and the verbals and nonverbals too. Not standing over someone, right? Think about an older adult in a wheelchair. How would you feel if you're sitting in the chair and I look down at you all day, right? Just think about what that potentially could convey and mean for someone versus pulling up a chair next to their wheelchair and chatting with them eye to eye. So build the rapport, raise the subject, explore the pros and cons of using too much alcohol or drugs, provide some feedback on the results of their audit or DAST tools. There are other tools out there that you can use as well. Talk about their readiness for change, build that into the conversation, and negotiating that plan for change. What is this going to look like for them? And again, this is predominantly framed around a harm reduction model. So pros and cons, you know, help me understand. What do you think are some of the good things or not so good things about using alcohol, right? And use your ORs. Open-ended questions, provide affirmations, be reflective in your listening, summarize what they're saying as you move through it. Asking permission and providing feedback. So I know it sounds a bit awkward, but it's so important to say, so I appreciate you filling out the audit and the DAST forms. Can I spend a few moments and give you some feedback on what these scores may mean? Why is that so important to ask permission? What's the opposite? Just telling them, yeah. Think about how often we're just told to do things throughout our entire lives. Our parents, a school teacher, right? Go do this, go do that, versus asking permission to provide some feedback. Give the information on the scores, you know. If you're working within a setting in which you've seen some of the challenges of drinking or drug use, you can normalize it. You know, in this setting, hospital, nursing home, assisted living facility, whatever, we've noticed that drinking X number of drinks a day compared to X number of drinks in a week may put you at risk for illness or with injury. You know, I've seen it with a lot of older adults at this assisted living facility. So I think it also provides this sense of they're not alone, right? So you're not the only person that is challenged by alcohol and drug use. That sense of normalizing is empowering, and getting the reactions to that. So what do you think about that? What does that potentially mean to you? And again, we'll hear the denial. I'm not that bad, right? Which is, I love that because that just means I'm not like the rest of them and my drinking and drug use is okay. So be cautious of that too. And the readiness to change ruler, right? So on a scale of 1 to 10, 1 being not ready at all and 10 being completely ready, how ready are you to make any changes to your alcohol or drug use? So patient says, I'm a 4. Well, what a great opportunity to affirm them that they're not a 2 or a 1, or that they have potential to get to an 8, 9, or a 10. I love this tool because this can be used for so many things. Talking about depression. Where are they with their depression today? Where are they with their readiness to make a change with regard to being in a violent or traumatic relationship, right? Think about different ways that you can use this tool in order to work with a client, especially long term. So if I come in today and I say to you, I'm like a 5 with my readiness to change for stopping my alcohol use, and then next week I come in and I say, I'm an 8 versus being a 0, right? So Michael, sounds like you're really, really making some progress about creating change in your life about alcohol use. That's really awesome. Versus, gee, Michael, last week when you came in, you were a 5. I wonder why you're a 1 today. What's been going on? Why has it been difficult for you with regard to your readiness or motivation to create change? So I just love the ruler. And then evoking a response or negotiating a plan for change. So, great. I appreciate the fact that you are willing to slow down or stop some of your drug use. I wonder what that looks like for you. And client says, I normally smoke every single day, smoke pot every single day. I think I'm only going to smoke every other day now, and I'm going to try that for a week, right? So again, thinking from a harm reduction model, this sense of negotiating with them what less usage might be. If it's, I don't even know the ounces anymore, but those big beers that you get sometimes that are almost this big, maybe they're cutting that in half. I forget what they're called, but different names. Or maybe if you don't provide this within your setting, getting that client to agree that they will see someone else, right? And that you provide that access or that linkage to some type of specialty treatment or service for the client. I don't have time to show you these, but I will make sure that you get this PowerPoint. They're a little dated, but they're 2 great examples of a doctor in an emergency room. One is an example of which he's doing a great job of using motivational interviewing, and one is a really bad example. So again, if you want to beg, borrow, or steal any of this and bring it back to your agencies or practice settings, these are 2 great video examples of using the SBIRT model. So referral to treatment may include any, oops, that got hidden over there. May include any of the following. It may include use of medications, counseling or psychosocial rehabilitative services, inpatient, outpatient, 12-step models, some type of complementary wellness, diet, yoga, religion, spirituality, meditation, some combination therein. I can't prescribe what that looks like for each individual. Clearly, you've got to look at individualized needs and willingness and readiness, and again, health insurance coverage, lack thereof, with regard to what treatment is going to be best for them. Who do you call? Do you have access to the resource information? Do you have to fill out a form? Do you have to get this into the patient's file or electronic health record? Who can help you do that if you don't know how to do that? So think about the planning process for referral to treatment. Don't rush, especially if the patient is not motivated for change, is not interested in making a change, they're not going to do it. So don't rush to do that. Be cautious again about thinking about coverage or lack of coverage and what that may imply for the referral or for the treatment. Know your referral base, right? What's in proximity to your organization, what's available, and I'll give you some city and state resources in just a couple of minutes. I know there's a lot of feelings about pharmacotherapy and the supportive treatment and recovery, but think about considering it, what it may or may not do. Again, I think keeping everything on the table is really important when making an appropriate referral to treatment. And again, be cautious about always assuming or thinking that all of our clients are resistant or self-sabotaging versus living with a chronic disease. So just be careful of stereotyping. The state of Illinois, this is specific to opioids. I borrowed some of this just from our presenter at the conference from CDPH. She provided some of these great resources, which I'm like, oh my God, I have to add this to my training now. So it is about sharing resources, right? You can order these cards through the state. There's the Illinois Helpline for Opioids and Other Substances, 1-833-2-FIND-HELP. And you can print these little cards out, have them in your office or waiting rooms. The Chicago Connects website at chicagoconnects.org. Your first click is to find help on this screen. And then you'll go to this screen, and there's resources for drug and alcohol treatment programs. Overcomeopioids.org, another great resource. for services programs, and some additional ones again through SAMHSA, ASAM, and a bunch of others. This is available on SAMHSA's website. It's a free handbook. It's really a wonderful resource for referral to treatment and talking about alcohol and drug use. And the infamous screening tool. Okay, so this, and I'm sorry for the moving on the video, this is kind of a cheat sheet for the SBIRT model. And on the first side, you will see the screening piece, which is looking specifically at usage for women and men 65 and over versus men under the age of 65, questions about frequency of use, amount of use, the substance use questions coming up next. You know, have you used drugs, thought about cutting down, been intoxicated, average serving sizes, drinks per day. We've got a little typo over here. So, but again, as I mentioned before, this continues to evolve when we look at the number of drinks per day and per week. After you've gone through the screening process, right, you've got to make this determination about probable risk. Are they at low risk, meaning they've had no yes responses to any of those screening questions, versus higher risk? They're drinking frequently, daily, more than intended. Their thoughts of cutting down are, they're not likely to cut down, could be harm to self or others. And then what do? Reinforce their behaviors, provide a brief intervention, or provide a referral to treatment. We'll flip it over. And the brief intervention, motivational interviewing piece here, all right, about the intervention, raising the subject, providing feedback, offering advice, enhancing motivation, negotiating a plan. They're the key motivational interviewing techniques, my fun little acronyms of ORS and REDS, open-ended questions, affirmations, reflections, summaries, versus REDS, rolling with the resistance, expression of empathy, developing discrepancy, support self-efficacy, and your own readiness ruler to have and to hold and to use forever and ever. Amen. These are great references that we used for the training. Again, most of these are kind of clickable links that you can use and have access to, various websites and resources. And there's a bunch of other resources up on our website at luc.edu/SBIRT. As well as the opportunity to do Cognito. Have you done Cognito? Heard of it? Anyone? Okay. I have time, right? You've done Cognito. Cognito SBI, or Short-Term Brief Intervention with Adolescents, is a free online simulation program. Go to this website, cognitocampus.com, and use the enrollment key Loyola SBI, completely free. You get 90 minutes, and you don't have to complete it in 90 minutes. You can start and stop. But it takes about 90 minutes to work with 3 adolescent patients in an emergency department. It's a really cool experience. The first adolescent patient, you come into the room, and he's broken his foot because he was out drinking with his buddies and fell off a porch. And you start going through the screening process with him. What's really cool about the simulated experience is that a bubble will pop up over his head if you're asking the wrong questions, like, I'm not telling him the truth, he's gonna tell my parents, right? So that makes you think, oh, did I ask the right question? What if I asked another question? There's a helper assistant that also pops up at the bottom and says, you know, you might wanna try to ask this, or you may not wanna ask that. Anyway, when we first got it a year and a half ago, I'm like, oh my God, I am not doing this for 90 minutes. Like and one Saturday I was like, how can I teach this if I don't do it? So I sat down on a Saturday and I started and stopped. I did one patient, then I went out, ran errands, came back, did laundry, did another patient. It's a really cool experience. I failed the first time. Like, I can't believe I'm not using the right motivational interviewing skills or like going through the brief negotiated interview with them. Anyway, it's free. It has unlimited use, so if you want to bring it back to your agencies or practice settings and promote it and say, hey, do this, there are CEUs available. I think it's a 1.5 or 2 CEUs that are available for social work and nursing. I'm not sure about medicine or other professions, but at least for social work and nursing, you can grab a couple of additional CEUs and you get a certificate at the end as well. So if you need that kind of certificate for your employee file or for HR, so it's a wonderful opportunity to put this into practice as well. So please use it. And that's me. So if I can be of any other assistance to you, shoot me an email, or we can provide these trainings at your practice site settings. Or as I said, to Kara or even Sam, if you want to take this PowerPoint and you feel confident in teaching it, go do it. Use my PowerPoint, put your name at the end, and teach the SBIRT model and motivational interviewing to your agencies. Again, this is not brain surgery, but I think it can have a really big impact, at least on the early intervention piece of looking at providing universal screening for alcohol and drugs across all settings with all diverse populations. And again, with the highlight today being specifically on a very marginalized group of folks such as older LGBT adults. So, got about 6 minutes, and I would appreciate your reactions or your questions or thoughts about today's training, or ways in which, any way that we can be a support for you from the School of Social Work. Sure. We will email it to you. So you signed in? Okay, so we have email addresses, and we just send them what we have. Send them both, it's fine. Okay? Yeah. Yeah, I think it's the latter. I think I would be very cautious because you don't know about truthfulness, and I would be very concerned about withdrawal. And again, this is my professional opinion. I would probably encourage them to think about a reduction, harm reduction, versus a complete abstinence. And again, this is a bit controversial because other people would say, no, it has to be all or nothing. Right, because think about this. If I'm drinking every day, and after the screening with you, I'm like, you know what? I'm going to stop today. Do you know what happens if that body is fully dependent upon alcohol or marijuana or heroin or whatever it is, and you stop immediately? What the health implications potentially are, mental health implications potentially are, right? So I'd be very cautious about that. It could impact blood pressure. It could impact suicide ideation. Like, there's so many different ways it could impact a person's reaction to completely being abstinent the next day. So I'd just be very cautious and probably lean towards saying to the client or patient, Michael, I appreciate that big willingness to make a change. I am concerned about your body's reaction to that immediate change. So I'm wondering if maybe there's some way we can talk about reducing your risk this week, and then next week, and then in a month. And then you might want to make a referral to a medical professional or other services and programs, outpatient or something like that. Other questions or comments or reactions? Busy filling out your important evaluations of us. Because it's a grant-funded project, we need to fill out the GIPRA. I apologize for the boringness of it. I'm sure the one from our student services crew is much more exciting. Well, I just want to thank you all for your time and thank you all for being here. And I'll hang out for a little bit if y'all have other additional questions. But good luck to you all in your continued work out in the field. And thanks to Amy and our amazing team in Student Services for setting all these events up. So thanks, everyone.
We're going to be collecting them on the tables out front. And if you had paid for CEUs, feel